Okay, so I'm going to go kind of quickly, but if I go too fast, just stop me or ask any questions. The way that I'd like to do this to make it the simplest is give you an overview of the anatomy and some of the function of the vestibular system, and then try to categorize common conditions that you're going to see. This isn't going to cover everything, but try to group it in your head so when you go into the room and somebody says, I'm dizzy, you kind of know where to go with things. Okay, so start out with on the first page is the vestibular anatomy. So you've got your outer ear, you've got your middle ear, and you have your inner ear. So when people say to you, oh, I just got my ears cleaned or I have a cold, that doesn't really affect the inner ear. That might affect the middle ear where you see the eustachian tube and the hearing mechanism, the bones of hearing, but it won't affect the inner ear unless it's a virus type of thing. And this isn't the best picture, those semicircular canals that are there are actually encased in bone. So you're not, fluid's not going to get in there unless you have a condition like a Meniere's or something medical like that. So that's the basic anatomy. If you turn to the next page, we go in a little bit closer here where you have the semicircular canals. So you've got the three canals there, and then you have the hearing apparatus, the cochlea on the side there. So we'll get a little bit more into the specifics of the semicircular canals. And if you look at the slide just below that, you get a top view of the semicircular canal. So it's almost like I think of it like an X on the top of your head. So if you look at the LARP plane, it's left anterior, right posterior. So you got one on the left that matches with the one on the right. Same with the right and the left on the right side. So it's like an X on the top of your head. And getting in even closer on the next page, so this is inside of one of the semicircular canals. You have this thing called a cupula, and I think of it like a sail on a ship. It's in the bottom left-hand corner there. So if you imagine like this Kleenex that I have here that I hold it up, as I move it, it billows out like a sail, or if I blow on it, it'll billow one way. That's what happens, but not with air, it'll happen with fluid. So you think of that canal moving, the fluid's going to move in there and it's going to kind of billow that sail out. It's going to tell your body, oh, I'm moving. So if you imagine if I'm turning this way, the sail on one side is going to billow one way and it's going to say, oh, my head's moving to the left. And it's going to do the opposite on the other side. It's going to tell it it's not moving that way. So that's how you get the signals in your brain. And we'll talk a little bit more specifically about the movement of the semicircular canals. And then in the bottom right-hand corner of that slide matches with the bottom slide there. Not only is there the cupula, but there's also these things called otolith organs, and I think of them almost like reeds on a lake. If you see the reeds, the wind blows and blows the reeds, it's the same thing. So you have one that's oriented vertically and one that's oriented horizontally. So you think about moving back and forth, those reeds move or they wave and they sense motion, more linear motion. Same thing with up and down. Okay, and again, we'll talk about that more in a minute, the function of it. So that's the main anatomy of the vestibular system. On page 4, then you also have the signal that's going through the vestibular nerve. You have a connection at the brain stem and then up to the cerebral cortex. And then obviously you have projections to the cerebellum that can control movement. So that's the basics of the vestibular system. Now as far as function on page 4, so vestibular system does 3 things. It senses linear movements, so you think about those otolith organs, you think about like going up and down in an elevator. When you go up, those little hairs move and they sense, oh, I'm going up. Or you hit the gas in the car and your head goes back, that's those otolith organs sensing that you're going forward and the hairs are bending back. So it senses linear movement. It also senses angular movement. You can see the guy skating on there. This is the semicircular canal. So you can imagine you've got an anterior and posterior on both sides, and you've got a horizontal canal. So when that fluid moves within the canals, it senses movement because that little cupula or that sail billows or waves and senses movement. Okay? And then the final thing is the vestibular system mediates eye function. or compensation to keep the gaze stable. And this is your vestibular ocular reflex. So you can imagine, if you see me focus on my thumb here, when I turn my head to the right, my eyes have to go to the left. And that's an automatic, that's a reflex. If I turn my head and my eyes don't go to the left, my eyes go over there, I lose focus on the object. That's what VOR is. And that's basically why you get nystagmus. You've seen nystagmus before. So if one side of your vestibular system is out, you're going to feel like, or your body's going to be thinking, oh, I'm moving this way. So if my head feels like it's moving this way, which way are my eyes going? They'll go the other way. So what happens is you feel like you're falling to the right, your eyes are going, drifting back and then snapping back, drifting and snapping back, drifting and snapping back. That's what nystagmus is. Okay, and that's what we see. And we'll talk about this a little bit more when you put the patient in certain positions. So you really need that function to keep your gaze stable. If your eyes don't do that, the image is either going to blur or you're going to lose it altogether as you're moving. And they even showed us a video in the course of, imagine you didn't have the vestibular ocular reflex, so as we're walking, we're just in a minute way, we're bouncing up and down as we walk. So as you go up, your eyes have to go down, even just a small way, imperceptible. But imagine you didn't have that, the whole world would be like this all the time. I was going to ring my Goldie bobblehead and it'd be like that all the time. But your vestibular ocular reflex takes care of that. So that's what's explained on page 5 there. So the VOR, as the head moves one way, the eyes have to move the other direction to keep the object in the visual field and focus. If it doesn't happen, you get blurring, and I already demonstrated that. Now, I like to paint pictures here so I understand the vestibular system a little bit easier. So if this helps you, great. Hopefully it will. What I think of is when I walk into a room and somebody says, I'm dizzy, I think of this lamp. And what it is when a lamp goes out, when you walk into the room and the lamp is out, what do automatically? You change the light bulb. That's the first thing you do. It's a mechanical problem. You put in the light bulb. But if that doesn't work, you may go and try another light bulb, but you probably think, nah, that's probably not the light bulb. So usually when the doctor gives you an order for BPPV and you go in and you check that, you check the light bulb, and it's not that, you got to go on to something else. It's either going to be the power cord, i.e. the nerve that goes back to the brainstem, or it could be even a central problem where it's a problem in the brain. So if that helps you to categorize the dizziness, and then we'll talk a little bit more about these categories. So the first one is BPPV. So when the lamp won't work, what's your first thought? You're thinking, because it's the most common problem, 80 to 90% are going to be BPPV, you go right to that, you do your testing, and we'll talk about what that testing is. But if that's not the problem, you're thinking it's probably a wiring problem, or it's probably at the junction box, you blew a fuse or something's a problem with a stroke or something in the brain. Okay? So what is BPPV? So we talked about the semicircular canals. They're filled with fluid or endolymph, and the problem is sometimes we get sediment, some people say rocks or crystals in this liquid. And so I always explain it to people like a snow globe when I go into the room. So I say, when you turn over the snow globe, the water stops, but the crystals keep moving. And it's bending that little cupula, and you're feeling like, ooh, I'm moving, ooh, I'm moving, ooh, I'm moving. And the classic thing with BPPV is it happens when you move in certain positions, and then it stops. You see how it completely stopped now, the crystals have settled. And then, I roll over in bed again. Oh, here it comes again. And maybe delayed by 10 seconds, but it's intense, and it lasts for 30 seconds, and it's gone. That's kind of a classic BPPV sign. I get it when I roll over in bed. I get it when I stand up. Or not stand up, but when I sit up from bed, because you imagine those semicircular canals are changing position and dumping those crystals. And this results in that sense of vertigo. Some of the classic signs, and you can get a lot of this from your subjective interview with a patient, even if you're not, if you're an OT and you're not treating this, somebody may say, oh, I'm terribly dizzy. You can ask them, well, what's going on? Oh, I always get it when I roll over. I get it when I get out of bed, and it lasts for 30 seconds. That's a great clue. You can come out of the room and tell the PT, hey, this is what they're looking at, and then boom, we're going to go right into our BPV testing. So you can get a lot of information just from your subjective. For symptoms, signs and symptoms, you get a spinning sensation. Things are moving in their vision. Can you imagine you're getting this nystagmus? So again, I feel like I'm falling to the right, my eyes are going to go to the left, then you're going to get this jumping sensation, which is going to impair your vision. Symptoms typically last 30 to 60 seconds, usually happens when they get out of bed, and they subside usually when they're upright. And symptoms are usually not constant. So I'm jumping ahead a little bit, but if the patient tells you, I've been dizzy for 3 hours, I'm dizzy while I'm laying here, does it come on when you're moving? No, I have it all the time. You're not thinking BPPV, because basically the snow globe is just sitting there. You haven't even moved at all. So I probably wouldn't be thinking the light bulb, I'm probably thinking the power cord, which we'll talk about in a minute. But so how do we test for BPPV? And a lot of you are familiar with this. So what we do is we do the Hellpike Dix. So you lay them back in bed with their head hanging. So if I wanted to test a canal back here, I'm going to tip them back and let those crystals fall. So sometimes I take the headboard off of the bed. Some patients can't tolerate that at all, so I put their bed in Trendelenburg, get them up and long sitting, and I put a pillow under their back, same effect, and then just lay them back with their head. Okay. You also, if the patient you're not able to do that in supine and they really can't get to the end of the bed, sometimes what I'll do is I'll do side lying. So I'll just have them turn their head and I'll have them bring their head down to the side of the bed. So basically you're just turning your head this way and laying down toward this canal, and you have the same effect. Okay? And we'll talk a little bit more about that in further seminars where you can actually practice it. Okay? So that's Hellpike Dix test. What you're looking for is you're looking for nystagmus. You're also noting the direction of this nystagmus. This is on the bottom of page 8. How long the nystagmus lasts, and note if the patient complains of vertigo. Now, you may not see nystagmus at all. You may get an intense feeling of vertigo, but you don't really see any nystagmus. That's okay. If it's got the classic symptoms, it lasts for 30, 60 seconds, it's in a certain position, it goes away when they're laying still, you can probably guess that it is BPPV, and then you can go ahead and treat that. Okay? It is helpful to know the direction of the nystagmus. We'll talk more about that in other seminars, but don't focus on that too much right now. Okay? And then, so that's for the anterior or posterior canal. So you can imagine, like, if I'm tipping the head back like this, I'm kind of tipping back and those crystals are going to fall. If this is the cupula right here, it's going to be kind of sucked down and it's going to trigger that nystagmus. Once this settles, after these drop down, 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 that's going to settle and the nystagmus is going to stop. Now, the horizontal canal is a little bit different. I think of that, I call it the steering wheel canal. Like if you're driving a truck or something, a big truck, instead of being in this plane, it's more in the horizontal plane. So for that one, you can be in the same position after you do your Hellpike Dix, but you bring their head up because the canal is tipped probably about 20 to 30 degrees. So you're going to want to tip their head up so it's vertical, and then you just roll their head from side to side. So you're going to roll them to the left, see if they get nystagmus. If they don't, roll them to the right, see if they get nystagmus, and then we'll talk about the treatment for that.
Is it just a head turn or the whole body?
Nope, just a head turn. Just a head turn. Now, if somebody had neck problems, I mean, I always try to screen people to make sure they don't have cervical problems. You can really do the same thing by rolling their whole body. So if they have neck restrictions, you can just roll them to their left side, roll them to the right side. It's a little bit more cumbersome than just turning their head, but you can do that too. So, okay. And then treating BPPV. So the main treatment is the cannula repositioning maneuver. It depends on the canal. This is on the bottom of 9. And canal involvement is determined by the direction of the nystagmus and the duration of symptoms. I don't want to get too in-depth on that, but there is a rather rare condition that instead of the the crystals being free floating in the liquid, they can actually be adhered to that cupula. So you can imagine if you rolled, now those crystals are going to be bending that sail down, but it's not going to stop. It's just going to be bending and bending and bending and bending, and they're getting nystagmus, and it goes on and on and on and on and on. That's a little bit different procedure where you have to break loose those crystals. But I don't want you to worry about that because that's really rare. I don't think I've ever had a patient like that before. And then we'll talk about which canal you treat in the continency, okay, and how to do that. Okay, so that's BPPV. So you go into the room, the doctor says, oh, they have BPPV, definitely. But you go in there and you ask them, well, when did your symptoms start? Well, it started a day ago. How often do you have? I have it all the time. Are you dizzy right now? Yes, I'm constantly dizzy when they're not moving. You start thinking, no, it's not the light bulb at all. You can even change the light bulb a few times. You can have them do Help-Like Dix a few times, and it's not going to change anything. So then you start thinking, it's probably the power cord, it's the nerve. So we're not always sure how this happens, but they think it might be a virus on the nerve. And you can imagine the vestibular system is a balance system, so it's got input on this inner ear and input on this inner ear. So imagine if I take out this inner ear completely, what am I going to feel like? I'm going to feel like I'm spinning to the left. That's what we call hypofunction, or sometimes they call it vestibular neuritis. You probably will see nystagmus, not always, but you think if I took this one out, I'm going to start feeling like I'm spinning to the left, which way my eye's going to go. They're going to fade to the right and then snap back. Fade to the right, snap back. Fade back, snap back. So you're going to get that continual nystagmus. It's really, there's no input on one ear, so that's why we call it hypofunction. So some of the descriptors down here in 10, think of it as a power cord problem. It's not a mechanical problem like BPPV. It can be sudden and intense like BPPV, but it's not provoked by position per se. It may get worse by position, but it's not. Classic BPPV, you move, you get the nystagmus, it stops, or you stop moving, it stops. Whereas with vestibular neuritis or hypofunction, it just kind of is constant, going on and on and on and on. It may be worse by movement, but it doesn't really stop. It doesn't take a break. Usually longer lasting, can be present when the head is still. Some signs and symptoms that you'll see on page 11. So dizziness, this is classic, dizziness even when the head is still. Symptoms that are longer lasting. You can get spontaneous or gaze-evoked nystagmus, and you have a positive impulse test, head impulse test, and I'll talk about that in a second. Gaze-evoked nystagmus or spontaneous nystagmus, so you may look at their eyes and they may just be jumping, just like this. Okay? And then they may look one way and the jumping increases, and they look the other way and maybe the jumping decreases. You won't see that in BPPV. You may see it when you tip them back, but not just when they're looking straight at you. So that's why it's important just to do a quick scan of their eyes. So do a letter H or an X on their eyes, and you'll find when they look one way, oh yeah, you see their eyes beating, or they may tell you, ooh, things are moving. Just when their head is still, so they're not even moving their head, that's a classic sign of vestibular neuritis or hypofunction, where one side is out. The other test that really brings this out is the head impulse test. So if you hold the patient's head and you move it slowly and then you give it a quick turn one way, you're eliciting that VOR reflex. So if I bring their head this way, in order for their eyes to stay on my nose, their eyes have to move that way. If you notice when you do their head impulse test, so I'm moving quickly this way, their eyes dart that way and then come back to my nose, that's an indication that on that side, would be on the right side for them, they have a hypofunction or they have a vestibular neuritis on that side. So that's a signal to me, not to get too technical, but something's wrong with that power cord on that side. It's not a BPPV type of thing, it's not a positional thing. It means something's wrong with the power cord on that side. Okay? So what do we do for testing for hypofunction? The first thing is get a good history. Just like I've been redundant in saying all along. Ask them about their symptoms. Ask them how long it's lasted. Ask them how it came on. Ask them if they only get it with position. That'll guide you down these tracks or these avenues to either be BPPV or hypofunction. Okay. The second thing is a good oculomotor exam. So if you just do your letter H or your X and you see some of that nystagmus, that'll tell you. Head impulse test is also really important. If they can't keep their gaze on your nose when you do that quick movement, you know that there's a problem with their vestibular system because they're VORs now. It's also helpful. I don't have time to bring these out or to show them completely, but it's also helpful to use the Frenzel goggles. So it's basically a goggle that is shaded on here, not shaded, but it's like opaque, so they can't see out of here, and there's a light that magnifies their eyes. Some people that have nystagmus can fixate through it. So you notice when you walk with patients with balance problems, what do? They're really rigid, they don't move their head, they keep their eyes focused right on you or on something. This takes that away, so it can bring out some of the nystagmus, so it's helpful to put the goggles on. Okay. And then the other helpful thing is to do the modified CTSB, so that's the standing with your eyes closed and then stand on foam or a pillow with your eyes closed. So you imagine if you had some vestibular hypofunction on one side, you're definitely going to feel like you're tipping the other way because you're spinning. So you may see with patients that have balance problems, you get some wiggle, you get some wobble, maybe they stumble a little bit. Somebody who has a serious hypofunction might just tip right over because they have one side of their vestibular system is out. Okay, all right. And then hypofunction treatment. It's a little bit longer lasting. These are the patients that I really want to get to outpatient. The BPPV patients, you can do the repositioning with them, clear the crystals out, and then come back and retest them, but it's pretty short-lived. You can get rid of these folks because one side is out. They really have to habituate and get their balance back, so it takes longer for them. So you want to do gaze stabilization exercises, so that's just simple VOR exercises. So picking a spot on the wall or looking at your thumb or an object and turning your head and keeping your gaze on that object. The way I tell people to progress that is a lot of them that are really having difficulty and a lot of dizziness, you just do your exercises laying in bed, as odd as that sounds. Pick a point on the TV or on the wall and you move your head from side to side. As that starts to feel a little easier or you start feeling better, try to pick up your speed a little bit. If that gets easy, okay, now let's try it on the edge of the bed. Let's do it in sitting. Oh, that's getting pretty easy. Now let's try it in standing. By that time, they're moving on, maybe going home, and then outpatient can pick up. You can even do this in walking. So walking and turning your head from side to side and trying to keep that object in focus. So that's the hallmark of hypofunction treatment. You also want to do balance training and gait training, obviously, because these people are going to be anesthetic. Okay? So we've got 2 tracks so far. We've got BPPV, we've got hypofunction. So you've checked the light bulb, you've done your halpytics and your roll test. You haven't found anything. You've done some hypofunction testing. It doesn't seem clear to me. Now you may be thinking it may not even be the power cord. It might be they had a stroke or something's going on in the central, in the box where the fuses are. So that's the last thing we're going to talk about, is central vestibular systems. Usually they're unchanged by position, so it's similar to hypofunction, but you get dizziness accompanied by other neurologic signs. So if you're doing your vision testing and they're complaining of double vision, that's not typically something that's involved in the vestibular system. If things are moving, you may feel like things are blurry, but they usually don't talk about true double vision. You may have speech changes, coordination changes, sensory deficits, all those things that you would do in a neural screen. And then one of the hallmark signs of central symptoms is direction changing nystagmus. So you do your little eye test and you see, oh, they got nystagmus on this side and it's beating this way. Now you go over here, oh, now it's beating that way. That's definitely a red flag sign.
Both eyes going that way?
So it would.
Is it one eye?
Usually with nystagmus, it's usually beating one way. They name nystagmus by the fast beat. So you actually, if you slowed it way down, there'd be a slow component and then a beat back, and a beat back, and a beat back. So it usually is, yeah, just beating, the fast beat is this way. In central conditions, sometimes you get a beat this way, and you have them look over here, and then you get a beat that way. That wouldn't really match because you wouldn't think, if one side was out, you should have extra beating. It wouldn't make sense to have it beat both ways.
Can you get that virus on both sides?
It is possible, and you can get bilateral hypofunction, so pretty rare. I mean, but it is possible, I suppose. That's a good question. And then how do you test for central involvement? So CT scan is not real specific or valid for finding posterior strokes. Even with MRI, they say 20% of strokes are missed in posterior circulation. So they're trying now more to use clinical testing to try to tease out they come into the ED, what's stroke and what's just vestibular hypofunction, because it can look the same sometimes. So they've developed this thing. Let me back up a little bit. You do your regular neuro testing, so sensory testing, strength testing, coordination testing, the heel to shin, rapid alternating movements, all of those things. And if you see something there, then you're going to be going down a neuro path or a central path. You can also do your cranial nerve screen. So if you have deficits in your cranial nerves, again, that's more of a central type issue. But sometimes what you can do to tease this out is use the HINTS exam. So HINTS stands for the HI's head impulse test. We already talked about that. So trying to bring out the VOR response. Nystagmus, which we already talked about. If you did your letter H or your X and you look for gaze evoked or just resting nystagmus, that's part of it. And then the last part is test of skew. So when you do vision testing, you can simply just cover one eye and then move to the other eye, and you want to see if the eye jumps up. So if there's a skew, the eye is gonna readjust when you cover the other, and it's going to jump up. And that's definitely a central sign. So the reason they developed this test is if you're doing your head impulse test, you might be thinking, oh, it's probably, and you get a positive on that, you might think, oh, it's the power cord. And if you've seen nystagmus, you might be thinking, oh, it's the power cord, but not necessarily a central sign. If you did the head impulse test and it was negative, so you got nothing on it at all, but you still got nystagmus, and you saw some skew, then you definitely would be thinking central signs. That's what the HINTS is to tease out. Okay, so how do we treat central vestibular disorders? Obviously, they have to see a neurologist if there's a central problem. That they need to treat them medically and get them stable. And then from there, we do some of the same things that we do for the hypofunction. We do gaze stabilization, so those VOR exercises, balance training, gait training, and then you may have to do some habituation if you have, say, a cerebellar problem. That can be, you can be really sensitive to motion. You might have to do some habituation to get them used to different movements to habituate to that. So that's the treatment for central vestibular. And then I wanted to highlight just some other vestibular conditions, and the reason that I put the percentages down there is these are very rare. So Meniere's is more of a pressure problem in your inner ear. It really needs to be treated medically to bring down that pressure, kind of like you would do with a patient with excess fluid in their body and they're trying to pull the fluid off. It's the same type of thing, but pretty rare, but it can give you dizziness. So the hallmark for this is, do you have sudden hearing loss? Do you have hearing loss? If they don't, it's probably not Meniere's because it's going to be affecting the hearing as well. Labyrinthitis is the same thing as vestibular neuritis or hypofunction, but you also, instead of affecting the vestibular nerve, you also get the hearing nerve as well. So you're going to have the same symptoms, but you're going to have hearing loss. So that could be one of your questions, and you're subjective. Migraine, 1 to 3%. This is the main treatment for this is medical management. They need to treat the headache, and then the vestibular symptoms will get better. Canal dehiscence, that's simply a hole in the semicircular canal. Again, very rare, but it changes the pressure in there and it can give you dizziness. You could ask them in the subjective if they get dizziness with loud noises, that type of thing. But again, this is going to be rare. This is gonna be one of those outliers that you ask for help on this one. Persistent postural perceptual dizziness. This is where a patient has a precipitating event like BPPV or hypofunction, and for some reason their body doesn't heal up and get better, and they have this chronic subjective dizziness that's going on for a long time. This is a patient where it's going to take a long time. They're going to need to go to outpatient. We're going to have to be patient with it. It's not going to be something we're going to fix here in acute, but just know that if they have this chronic vague dizziness, you need to get them stable and balanced, stable in their mobility, and then have them get to outpatient to help them with this. Concussion. Again, you can get symptoms with this. I just wanted to highlight it's rare that you get a lot of vestibular system symptoms with this, but you can. And then the last one is alcohol-induced vertigo. So people come in with intoxication. That can change the buoyancy of the fluid, which again changes how that sail works. And so you think about when people are drunk, you know, when they get dizzy or they get spinning, they have to detox and come down for that. And then some of those symptoms will subside. Any questions at all? Well, hopefully that helped.
Yeah, I had never heard of that possible persistent postural.
It's changed names. I think Billy said she learned it was functional dizziness. I've heard of it chronic subjective dizziness.
Looks like it's
I
done.
had somebody up for
Yes.
a couple weeks ago, like what they ended up having.
Yeah.
And I was looking it up and I'm like,
Did she try?
what?
Was she inpatient?
No, it was a patient. Yeah, it was an inpatient.
Oh, okay,
They
okay.
weren't there for that, but.
Oh, okay. Because we had a lady here who was going to go to the
Yeah,
clinic
it was
at
a- it was a
Frank. Okay.
Yeah, I mean, dizzy every single time.
Yes.
she sat up,
Yes.
And honestly,
Yes.
it just wasn't, but he was like.
I don't know if it's on the
not better for
Yes.
him.